Hello, my name is Katya Ringler, and this is my submission for the Case Connection 3 assignment. In the first case I chose, we're studying the metabolism of non-alcoholic fatty liver disease in a 53-year-old male. So, under normal conditions, for metabolism in very low density lipoproteins, also noted as VLDL particles, they are metabolized in muscle and adipose tissue by lipoprotein lipase. This is an enzyme and it hydrolyzes triglycerides and releases as fatty acids when it's activated by the apolipoprotein C2. So the removal of the triglycerides, it forms IDL, which is also known as the VLDL remnants. This gets further converted to LDL from um, apolipoprotein E and apolipoprotein C2. And LDL is low density lipoproteins. So these apolipoproteins E and C2, they're sourced from HDL, high density lipoprotein, and then they're returned once they're used. So VLDL metabolism leads to the development of LDL. And looking at the maturation of VLDL particles, we start with nascent VLDL particles, and those are formed in the liver from apolipoprotein B100, triglycerol, triacylglycerol, phospholipids, and de novo cholesterol. The particles, they'll take up C2 in apolipoprotein E from the circulating HDL, which I mentioned, and they mature into the VLDL. And then at the end of the VLDL metabolism, we get the maturation product LDL. Now, when we're looking specifically at the non-alcoholic fatty liver disease and how it manifests, we see multiple causes. The most popular causes are related to the health conditions. So, some common health conditions associated with NAFLD are obesity, metabolic syndrome, type 2 diabetes, abnormal levels of cholesterol. And then NAFLD is also found to be more common in different racial and ethnic groups. So this also suggests that the genes also play a role in its manifestation. And then lastly, diets high in fructose have also been shown to increase the risk of NAFLD due to its lipogenic effect. And then the insulin resistance that's associated with this condition, it affects the function of LPL, which we talked about was a major enzyme in VLDL metabolism. So because the breakdown of fatty acid is impaired, this suggests that the fatty acid oxidation is also disrupted. So this metabolic disorder decreases fatty acid oxidation, which leads to free fatty acid accumulation and the development of non-alcoholic fatty liver disease. So this concludes the first case, and now we'll move into the second case. So this case, we're looking at hormone status and its effect on metabolism. And we are looking at a 48-year-old female and studying some of her vital signs and her charts. So after analyzing the patient's laboratory tests and her vital signs, there are a few conclusions that can be made regarding her hormonal status. So when studying the blood glucose, there are two main hormones that play a role in maintaining homeostasis. We are looking at insulin and glucagon. So the patient's highest blood glucose level reading was 221 milligrams per deciliter, which compared to normal levels of 70 to 105 milligrams per deciliter shows that it is very high compared to the normal values. And this indicates that the patient is not using glucose due to either a deficiency or a resistance, and we understand this disorder as diabetes mellitus. Diabetes can also be characterized by the HbA1c measurement, and hers was 7.9%, and the level that is categorized as diabetic is 6.5%, so that is also an indicator as well. So insulin influences glucose, lipid, and protein metabolism. Insulin resistance in cell changes lipid and lipoprotein metabolism, and this causes dyslipidemia, or the imbalance of lipids. These changes are presented by the raised levels in LDL, triglycerides, and total cholesterol in the patient. Normally, total cholesterol should be 125 to 200 milligrams per deciliter in healthy patients, and the LDL should be below 100 milligrams per deciliter. And we see this doesn't really match up with the patient's markings, as her total cholesterol is 308 milligrams per deciliter, and her LDL is 208 milligrams per deciliter. And then, so the second part of this case, we're studying the different kind of treatment plans that are possible for patients that have these indications. The first therapy presented is statins. Statin works to decrease the amount of LDL and triglycerides in the blood, and this is acquired by inhibiting HMG CoA reductase, which is an enzyme that's responsible for cholesterol synthesis. And by reducing the concentration of cholesterol, it increases the expression of LDL receptors. And then this clears out the LDL from the circulation. And then statin is generally considered safe. However, there are several side effects that are associated with its use. The most common of these include liver and muscle toxicity, which can be displayed through symptoms of muscle weakness, muscle pain, or fever. The next possible treatment suggested was PCSK9 inhibitors. These bind to the protein PCSK9 to increase the number of LDL receptors to the surface of the cell. And just like in the other treatment, this clears LDL cholesterol from the circulation. The LDL receptors can reduce the LDL cholesterol more efficiently, therefore, it decreases the LDL concentration. And for possible side effects for this treatment, most people usually don't experience severe side effects, but it is important to be aware that you may feel muscle fatigue or soreness. Now, the last potential therapy is bile acid sequestrants. These reduce plasma cholesterol through malabsorption of bile acids in the intestine. So when they're ingested, it doesn't get digested or absorbed, but instead it binds to the bile acids. So this prevents enterohepatic circulation and promotes the conversion of cholesterol to bile acid. And then this ultimately decreases LDL and cholesterol. Now, the most common side effects that are associated with bile acid sequestrants are related to the gastrointestinal issues. and these can be presented as constipation, stomach pain, bloating, indigestion, and vomiting. This concludes my assignment for the case connection 3. I have a list of all the references that I used throughout the slide, and you'll find the references either in the text or at the bottom of the slide. Thank you.